Well child care includes anticipatory guidance, which is an important aspect of every well child visit. Commonly discussed advice includes keeping the water heater at less than 48.8 degrees Celsius, 120 degrees Fahrenheit. Babies should sleep on their backs without any stuffed animals, toys, or bottles in the crib to decrease the risk for sudden infant death syndrome, SIDS. Car safety seats should be rear-facing and placed in the back of the car. Seats can face forward if the child is older than 2 years of age and weighs more than 18 kilograms, 40 pounds. No solid foods should be given before 6 months of age. Solid foods should then be introduced gradually and one at a time. Cow's milk should not be given before 12 months of age, as it increases the risk of iron deficiency anemia. Syrup of ipecac, an emetic, is no longer routinely recommended for accidental poisoning, and poison control should be contacted immediately for assistance. Other important guidance during a well child visit includes advising that children wear helmets when riding bicycles, and that parents ensure firearms are unloaded and securely locked away. Smoke detectors should be installed in the home and kept in working order. Intake of sugar-sweetened drinks and juices should be strongly discouraged, and juice should be avoided before 12 months of age. Adolescents should receive safe sex education, and screen time should be limited for all children, especially those younger than 24 months, as hands-on learning is essential for development. Sudden infant death syndrome, SIDS, is the most common cause of unexplained death in children under 1 year of age, with an unknown pathogenesis. Brief Resolved Unexplained Event, BRUE, is an episode lasting less than 1 minute with no known cause, presenting with an abrupt change in respiration, decreased responsiveness, cyanosis, and change in muscle tone. BRUE is no longer thought to be a precursor of SIDS. Clinical case. The mother presents with her previously healthy 3-month-old infant boy, stating that he has been increasingly difficult to rouse for the past 4 hours and has lost interest in feeding. She left the baby alone with her boyfriend while she ran errands. While en route to the hospital, the baby stopped breathing. PE is notable for occipital bruising. What is the most likely cause of this child's apnea? The most likely cause of this infant's apnea is abusive head trauma, which is most common in 3 to 4-month-old infants and presents early with nonspecific symptoms: lethargy, irritability, poor feeding, vomiting, and later with seizures or apnea. There is generally no reported history of head trauma. Subdural hematoma and edema account for most neurologic findings. In babies with abusive head trauma, there is a 50–70% chance of prior abuse. Objective hearing screening using otoacoustic emissions and/or auditory brainstem response for newborns before hospital discharge is the standard of care. Children who fail these screening tests require further diagnostic evaluation. Objective hearing screening is also indicated for children with a history of meningitis, torch infections, measles, mumps, or recurrent otitis media. The most common cause of childhood conductive hearing loss is repeated ear infections. The red reflex should be checked at birth, as leukocoria, the absence of a red reflex, can indicate retinoblastoma. It may also be seen incidentally in early infant photos. Vision screening to detect strabismus, amblyopia, and other visual disorders should be performed at every health visit in children under 5 years of age. Strabismus is considered normal until 3 months of age. Persistence beyond that warrants evaluation by a pediatric ophthalmologist and possible corrective lenses, occlusion therapy, or surgery to prevent amblyopia. Treatment of strabismus involves patching the normal eye to strengthen the weaker eye and improve its muscle control. Leukocoria is a key finding that may indicate retinoblastoma, congenital cataracts, or retinopathy of prematurity, and all cases require immediate ophthalmologic evaluation. Childhood vaccinations follow Centers for Disease Control and Prevention (CDC) recommendations. Contraindications include severe allergy to a vaccine component or a prior dose of the vaccine. Patients with life-threatening egg allergies may still receive measles, mumps, and rubella MMR, and influenza vaccines under medical observation, though caution is advised when administering yellow fever vaccine. Other contraindications include encephalopathy within 7 days of a prior pertussis vaccination, personal history of intussusception, and severe combined immunodeficiency, SCID, which contraindicate the rotavirus vaccine. Live vaccines, including rotavirus, oral polio, varicella, MMR, intranasal influenza, and yellow fever, should be avoided in immunocompromised or pregnant patients, except for HIV-positive patients with CD4+ counts greater than 200 cells MM superscript 3, who may safely receive MMR and varicella vaccines. Precautions include moderate or severe illness with or without fever. Prior significant reactions to pertussis vaccine, such as fever above 40.5 degrees Celsius, 104.9 degrees Fahrenheit. A shock-like state, persistent crying for more than 3 hours within 48 hours of vaccination, or a seizure within 3 days of vaccination, as well as a history of receiving intravenous immunoglobulin within the past year. Mild illness, low-grade fever, current antibiotic therapy, and prematurity are not contraindications to vaccination. Premature infants should receive all routine vaccines based on their chronological, not gestational, age. Most exposure in children is caused by lead-contaminated household dust from lead paint. Screening should be routinely performed at 12 and 24 months of age for patients living in high-risk areas, such as pre-1970s homes or zip codes with high percentages of elevated blood lead levels. Universal screening is not recommended. Children are usually asymptomatic. Children under 6 years are most susceptible to the effects of lead because of an immature blood-brain barrier. Common symptoms include peripheral neuropathy, such as wrist and foot drop, cognitive impairment, colicky abdominal pain, constipation, headache, hyperactivity or apathy, and anorexia. Acute encephalopathy, usually with levels greater than 70 μg/dL, is characterized by increased intracranial pressure, vomiting, confusion, seizures, and coma. New evidence has shown impaired intelligence and neurodevelopmental outcomes among children exposed to lead levels as low as 10 μg/dL. The physician should do a fingerstick test as an initial screen at 1 or 2 years of age. If elevated, then a serum venous blood lead level should be obtained. CBC and peripheral blood smear show microcytic, hypochromic anemia, and basophilic stippling. Sideroblastic anemia may also be present. Note that concurrent iron deficiency anemia may also be present, as both lead poisoning and iron deficiency share similar risk factors. X-ray of the abdomen may be useful in assessing for ingestion of objects containing lead. For treatment, if venous blood lead concentration is less than 5 μg/dL, provide family education and perform an annual blood lead test. For 5 to 14 μg/dL, retest at 1 to 3 months and remove exposure. For 15 to 44 μg/dL, retest within 1 to 4 weeks and remove exposure sources. For 45 to 69 μg/dL, retest within 48 hours. Perform further workup, such as X-ray of the abdomen and electrolytes, and begin oral Sixymer therapy. For levels above 70 μg/dL, retest within 24 hours, hospitalize the patient, and initiate chelation therapy using Sixymer plus editate calcium disodium. Perianal dermatitis is commonly seen in infants and children. Irritant contact dermatitis is the most common type in infants, presenting as an erythematous rash that spares the skin folds, classically due to skin breakdown from exposure to urine or stool. It is treated with topical barrier ointments, such as zinc oxide or petrolatum. Candida diaperdermatitis is the second most common form in infants, presenting as beefy red, confluent plaques with satellite lesions that do not spare the skin folds. It is treated with topical antifungal agents, such as nystatin. Perianal streptococcus occurs in school-age children as well as infants, presenting as a red, sharply demarcated perianal rash with associated pruritus and pain. Blood-streaked stools or constipation may occur from withholding stool due to pain. Diagnosis can be confirmed with a perianal bacterial culture, and treatment involves oral beta-lactam antibiotics. Pigmented lesions in childhood include congenital melanocytic nevus, congenital dermal melanocytosis, and ck2 spots. Congenital melanocytic nevus is a benign proliferation of melanocytes with an increased density of hair follicles, presenting as solitary hyperpigmented lesions with coarse hair. The melanocytes may enlarge during infancy, and large lesions are often surgically removed due to an increased risk of transformation to melanoma. Congenital dermal melanocytosis, also known as Mongolian spots, appear as multiple poorly circumscribed, non-tender, flat, blue-gray patches that do not blanch, often located on the lower back and sacral region. These lesions fade spontaneously during childhood and are more common in people of Asian and Black descent. They may be mistaken for bruises due to abuse. However, bruises are tender, show color variation, and fade quickly. The presence of congenital dermal melanocytosis should be documented on initial evaluation. ck2 spots are flat, hyperpigmented patches with a coffee with milk appearance. Isolated spots are most often idiopathic and benign, but multiple ck2 spots may be associated with McCune-Albright syndrome and neurofibromatosis.